Welcome, freshman class. This is your first lecture of nursing school in Nursing Fundamentals NUR 110. Today we'll be discussing the topic of safety in patient care and safety in nursing. So we'll start out by talking about who exactly is responsible for safety for the patients. The easy answer to that is everyone who works with that patient is responsible for safety in their care, in their everyday well-being, and we're always trying to promote wellness and safety for our patients. Safety and security is a basic human need. As nurses, we always need to be looking for and identifying potential hazards that we could see in our patients' environment, in their everyday lives, and help promote wellness for our patients, accident prevention. Safety keeps us free from danger, harm, or risk, and it's very important for you to understand that safety underlies all of our nursing care. It is the number one priority when providing patient care. When it comes to this, the big key here is prevention. That's how we can promote safety for our patients, preventing those hazardous environments, preventing accidents from happening. It's not always easy, and it can be a challenge. Some things just to consider, some things to think about. What do you do if you see maybe a fellow healthcare worker who's maybe not providing the safest environment for their patients? Maybe they're falsifying documentation, like they documented care was done, but it really wasn't. Maybe they're documenting false vital signs. How do you handle those situations? And we always need to make sure that we are addressing those situations because, again, at the forefront, we must keep patient safety number one. We do know that in healthcare, a safe environment will reduce the length of treatment and hospitalization, the frequency of treatment-related accidents, the potential for lawsuits, the number of work-related injuries to healthcare personnel, so that's something for you as a nurse to think about and consider, and the overall cost of healthcare services in general. When we think about safety, we have to consider what are the risk factors that are involved that put us at risk for injury, accidents, and how do we prevent those. So we'll start by looking at just everyday life. What are some lifestyle choices or maybe occupations that are high risk? Okay, some examples we have here. The farming industry, industrial workers, operating heavy machinery, very high risk. For nurses, okay, needle stick injury, back injury from lots of lifting and straining, even latex allergy due to frequent exposure. Okay, so those are some concerns in healthcare. Excessive noise exposure can lead to hearing loss over time, so that can have some long-term effects. Repetitive motion and movements can lead to carpal tunnel syndrome over time. Also, those people who tend to be more risk takers in life, maybe not wearing seat belts, in vehicles, maybe not wearing helmets. That could be children through adults, in motorcycles, automobile accidents. Those are very risky behaviors. And then the environment that we live in, especially those people who live in higher crime environments and areas, those are obviously putting our safety at risk. Mobility factors, okay, people who have an unsteady gait. And gait means your walk, okay, the ability to walk and how steady and safe is that. That can be due to many different reasons when somebody has an unsteady gait. It could be due to advanced age, decrease in balance over time. Could be due to a disease process. Even possibly medication side effects is something to consider. If someone has a cast on an extremity, if there's any paralysis, weakness in extremities. Prolonged bed rest or inactivity definitely takes a toll on our mobility and getting back to that mobile state. People who use mobility aids such as crutches, canes, walkers, we always need to make sure that patients are using these correctly And also, as nurses, we can provide instruction for our patients on how to properly use those. If a patient has had recent surgery or prolonged illness, that definitely takes a toll on our mobility. The human body is designed to be mobile and to move. Our musculature, all of that is meant to be in a mobile state. We are not meant to be stationary, and that takes a toll on our body when we are inactive or on prolonged bed rest for long periods of time. Some sensory alterations to consider: decreased sense of smell. Think about this, how that could affect someone's ability to detect maybe a gas leak in their home. Maybe they can't, without that sense of smell, they can't tell if there's food that's spoiled, and then that could affect them and cause them to be ill. Decreased hearing, that abbreviation HOH is hard of hearing, and that of course affects our environment. If we aren't able to hear things in the environment, that puts our safety at risk. Impaired vision, of course, paralysis, medications, particularly narcotic medications, pain medications, can affect our cognition, decreases our kind of environmental awareness, makes people groggy, so that definitely can have some sensory alterations with it. And then can decrease the ability to know what is going on in the overall environment. Any of these things listed can have that effect. Our knowledge base, if we don't have the knowledge base of what medications we're taking, if patients are lacking that knowledge and they don't know what side effects to look for, that can put their safety at risk. If a patient is experiencing confusion or disorientation, whether that be an acute or a chronic issue, that definitely puts their safety at risk. They don't have that cognition and that cognitive ability to know what's safe and what's not safe. Lack of sleep, of course, can affect our ability to make good decisions, and then in a state of unconsciousness, that affects our safety as well. Our communication. Some things to always consider, when we're communicating with our patients, and we want to utilize those steps in safety, something to think about like prior to medication administration. We always make sure that we are identifying the correct patient and, before we administer that medication. So what are the things that we ask? Okay, we always ask the patient two things. One, what is your name? And two, what is your date of birth? And we want to see that the patient is able to tell us those things correctly. One, that tells me that they are oriented, they are alert and aware of what's going on. They also, are able to hear me, they're having good communication. So that helps me kind of clue into a couple different things there. We also want to know, if a patient has an inability to read, is it a visual problem, or maybe there's a lack of education? Is there a language barrier? And that can put safety at risk, very much so, because if I'm communicating health information to the patient and there's a language barrier there, they're not understanding what's going on with their health, so that's a safety risk. Aphasia, meaning difficulty either expressing a message or receiving that. So expressive aphasia, patient may not be able to tell us what they need or what's going on. Receptive would be they can verbalize, but if I'm giving them a message, they're not able to understand that or receive that. And then patients who have hearing deficits as well, that can cause lack of communication. So anything that affects a patient's overall health can, of course, affect their safety. So thinking about neurologically, a person's judgment, which is just the capacity to assess situations or circumstances, draw good sound conclusions, and basically is having good sense. So if there's any kind of alteration on neurological status, that can affect our judgment. Orientation, that is the ability to tell us things like they know who they are as a person, place, time, where they're at, the situation. We're assessing for confusion when we assess a patient's orientation. So again, to assess if they know who they are as a person, I ask name and date of birth. Place, I usually ask them, do you know where you are today, what facility you're in? Time, typically I ask the patient what year is it. Sometimes days can tend to run together if they've been like in the hospital for an extended period of time. So sometimes the year is a little bit better option. And then the situation, ask the patient, what are you here for? Or why are you here seeking treatment? So those are good things to ask the patient, and that lets us know if their neurological status is intact. Looking at their balance, if they have any dizziness, things like that, that can also go along with the neurological impairment. The cardiovascular system or respiratory system, any alterations in those, if apnea, which means shortness of breath, that of course can affect their safety if they're not able to be mobile for long periods of time, and they experience that puts them at risk for a fall, for some injury. Fatigue or decreased tolerance for activity, or just experiencing limited mobility over time, that can cause effects on those systems as well. Looking at the patient's skin, we always, when we do a really detailed assessment on our patients, we want to look for any clues of accidents or injuries. Maybe things such as old bruises, cuts, scratches, scars, anything of that sort. Mobility, we want to check their range of motion. ROM is what that stands for. And do they have good range of motion? Are they able to move all their extremities freely without any difficulty? What's their muscle strength like? What's their posture and their gait? Again, the walk, and is it steady? Are they swaying? Anything like that. And then, can the patient safely perform activities of daily living? That's ADLs. And are they able to do these things independently without any assistance and safely? So are they able to dress themselves safely? Are they able to bathe themselves safely, feed themselves? All of those things we need to assess and make sure there's no concerns there. Psychosocial factors. Okay, stress. Stress in life definitely can have an effect on our judgment, on our attention span. It can definitely narrow a person's attention span, causing increased risk of accidents, makes you very distracted. Anxiety, depression, causes kind of a decreased concern about hazards in the environment. Just a very overwhelming sense of fatigue can decrease the perception of danger, can decrease problem-solving abilities. Anger can also have an effect on our safety. So in the nursing process, where we usually start is with assessment of the patient, okay? And so we'll start by talking about getting a nursing history. And we need to look at, what are the patient's concerns and their perceptions of any hazards in their home environment, or even in the hospital environment, long-term care facility environment, wherever that is. And we also need to ask the patient, have they had any history of falls or any accidents? Consider the age group. Okay, our high-risk age groups are our younger patients, infants and toddlers, in that age where they're learning how to be mobile and walk. And then our elderly population. Typically we consider anyone 65 and older as a higher risk for a fall. So those would be our high-risk age groups we would need to definitely assess for. Recent changes in the environment that could throw off their sensory perception. Support system, do they have family, friends, neighbors, who is there for them, who's there to help them on a daily basis if needed. Does the patient have any history of drug or alcohol abuse? That of course can affect cognition, judgment. And then we look at physical exam. Their mobility status. Is this patient 100% independent and able to do things on their own safely, or do they require some assistance? And that could be whether it's one person or two-person assist, but whatever they need to be mobile and to be safe. Use of assistive devices. Do they use any walkers, canes, crutches, and are they using them properly? Do they have an adequate means of communication, ability to communicate? Are there any sensory perception alterations, and recognize those, and make sure that they are using any assistive devices, glasses, hearing aids, cochlear implants, whatever, as some examples, but whatever it may be, are they using those? Are they functioning and working properly? We also need to recognize any signs of abuse or neglect in any age population. Just always be alert for those and on the lookout for those. Assessment of the home environment or even the environment in a healthcare facility. Do they have adequate ventilation, proper lighting? Are there any obstacles in the way that could be like a tripping hazard, bathroom hazards, wet floors, slick rugs, things like that can slip. Lead exposure, in the home, like older homes that have lead paint, pollution. Are smoke alarms working properly? Do they have a fire escape plan? Adequately maintained electrical appliances. Those can be a fire hazard as well. And looking at a fall risk assessment, just to introduce this here, we will get into this in more detail here in a little bit, but we always assess a patient's fall risk. Every shift, every time we take care of a patient, we need to look at, what is their risk for injury. As mentioned earlier, falls are much more common among older adults, as well as young children, infants and toddlers, so those would be our high-risk age groups. These falls can result in some serious consequences. Could be permanent disability, pain, broken bones, all kinds of complications, and ultimately, especially for the geriatric population, that could ultimately lead to death. So there are some very serious concerns with this, and that's why it's such a high priority that we assess this and that we prevent falls. So anyone who has a gait or balance disorder, any weakness, dizziness, if they're in an environment that has poor lighting, lots of stairs or just obstacles on the floor to navigate around, if the patient is taking any sedating medications, if they have a history of depression or substance abuse, if they're experiencing incontinence, confusion, visual impairment, and then again, our high-risk age groups, the young infants and toddlers, and our geriatric population, our older adults, those would all be people that I would consider a very high risk for falls. So we would definitely want to watch them very closely. There are many different fall risk assessment tools that can be used, and you're going to see different variations of these in lots of different, healthcare facilities. So I will introduce you guys a couple of examples in this lecture. Just know that they can be different, though, in different healthcare facilities. But ultimately, the main goal is that we use these fall risk assessment tools to identify a patient's risk factors for a fall. And after we identify those risk factors, we total up the score, and that's going to correlate with their risk. So in general, most fall risk assessments total up scores of, starting at 5 to 7. We consider those patients a moderate risk for falls. 8 and higher, we would consider a very high risk for falls. So just know, again, that these tools can vary a little bit. This risk assessment tool here is one example that I give you guys. So as you can see, the main areas that they focus on, has the patient had a previous fall in recent history? Some scales will say within the last 3 months, if they've had a fall. Statistically, it shows that patients have a higher chance of falling again if they've had a recent fall. So that would allow 3 points towards their score there. So that's a high point score there. Disorientation, confusion, or a combative patient would be 3 points. Impaired mobility, 2 points. Taking a narcotic, pain medication, a hypnotic medication, or a sedative would be 2. Impaired eyesight, 2. If they're taking medications that are diuretics, which are going to make them, pee more because they're going to be trying to get fluid off. Also laxatives, just to help increase bowel movements. So that just makes patients a little more impulsive to want to jump up out of a bed or out of a chair, and to get to the bathroom quickly. So that puts them at a higher risk for a fall. That's one point. Orthostatic hypotension is a patient who maybe goes from a lying position to standing, and it causes their blood pressure to drop. So that would be a point there. If their age, now this scale has 80 years or older, or those under 3 years of age, that's a point there. So their age groups vary a little bit. If they've had surgery recently or a special procedure in the last 24 hours, due to the types of medications, sedating medications that patients receive with those, that puts them at higher risk. And then impaired hearing. So you would just go through the scale and identify all the risk factors that your patient had, and then you would total up their score. And again, for this one, 5 to 7 would be moderate risk, 8 and higher would be a high risk for falls. Okay, so we'll move on talking about fire assessment, specifically in the home environment. We need to assess, our patients at a higher risk for experiencing a fire in the home. Most fires do happen at home in that environment. So things such as careless smoking, faulty electrical equipment, unattended cooking, candles that are lit for long periods of time or unattended, kerosene heaters, children that have access to matches, lighters, could be playing with those, grease fires. Any of those are what we would consider risk factors for a fire in the home. Fire assessment in the healthcare facility. There are many things that are a risk for starting fires in the healthcare facility. Example, oxygen is flammable, and again, mixed with smoking, that can cause a fire. So we got to make sure that patients are taught that it's not safe to smoke while wearing oxygen, and also that they understand that when going home, if a patient's going home on oxygen, the safety risk there. Anesthetic agents, some of them are flammable, so those, kind of a safety risk there. Any malfunctioning equipment, electrical equipment, here's pictured like an IV pump, if anything's malfunctioning, wires frayed, things like that, that's a risk for fire. Poisoning is a risk, and we have to consider all the different age groups and what we see most commonly with those. What we consider the highest risk would be young children, and again, into like older infants into toddler age, where they're exploring their environment and getting into things they shouldn't. Older adults, that could be maybe because of if they have impaired vision and they're not, taking medications appropriately because they can't read the labels, that could lead to a poisoning event. Adolescents, we can see alcohol poisoning, drug overdose, things like that. Some other things to consider in the home: household cleaners, and that children can get into medications that are improperly labeled or not stored, like in childproof cabinets. Plants, there are plants in the home that can be poisonous, so those need to be moved out of reach. Paint products, lawn and garden chemicals, spoiled food. It's always important for parents, if there's any children in the home, they should have that poison control center number, so that way in an event they have that number to call right away and see what their action should be. In your fundamentals textbook, on page 695, there is a list of common agents that are seen in childhood poisonings. Just a couple of examples: Tylenol or acetaminophen is on there, lead poisoning, things like that. So that's a good table just to look through. It's table 26-1. Just take a look through that and just to be aware of what the most common poisoning agents are that we see in children. Suffocation, of course, is a big safety concern. That's just airway obstruction. Could be due to, drowning, smothering, strangling, choking, leading to suffocation. Those at risk: infants, big safety things to consider. No pillows or blankets in the crib. With an infant, they should be sleeping alone in a crib. There's a risk of smothering if they're sleeping, in bed with parents. Toddlers, they can choke and suffocate on things like small toys, little small plastic pieces, plastic bags, even choke on plastic pieces from balloons, so they should always be supervised when playing with any of those things. Older adults, that could be, they can experience choking on food that maybe is not chewed well enough, and then that can lead to a suffocation event. So those are just the high risk age groups, but just know that, of course, it can occur at any age. Firearm injuries is something to think about in the home environment, and there are some good safety rules here that especially parents of small children, they need to be aware of these and follow these to help protect their children and keep them safe. But firearms in the home should always be stored in a locked cabinet. Store the bullets in a different location from the guns themselves. Tell kids, especially older children, to never handle a gun unsupervised, and if they're staying like at a friend's home where there is a gun accessible, make sure that it is locked away. If it's not, it might not be a safe home environment to go to. Never point the barrel of a gun at anyone. Teach kids that that's never safe to pretend or play like that with the gun. Ensure it is unloaded when handing it to someone else. Don't handle firearms while under the influence of alcohol or medications that can affect judgment, things like narcotic pain medications. When cleaning them, be sure to remove the ammunition to another room, and all firearms should be regularly inspected every 2 years just to make sure that they're working properly. All right, so the next step in the nursing process here is nursing diagnosis. We talked about assessing the patient, assessing maybe the home environment, those situations. Once we assess all of that, then we can identify what the safety problems are, and we can formulate a diagnosis. So some examples I have here for you of nursing diagnoses. Okay, these all relate to the topic of safety. Here's one: risk for injury. Okay, and that can be very broad. That can encompass a lot of different things. Maybe a patient has deficient knowledge about their health, maybe about their medication regimen, about their treatment, and that could be a safety risk. A readiness for enhanced knowledge. That's a patient who's asking for more information, wanting to know more. Risk for poisoning, that can apply to maybe those younger patients, pediatric patients who are the high risk age group, and of getting a hold of those common poisoning agents. And then risk for falls, that's a really common one that you're going to see used for patients either in the long-term care setting or like in the hospital setting, an acute care setting. And that could be due to a lot of different things. It could be due to unsteady gait, it could be due to advanced age, due to medications, lots of different things. So just to introduce you to what nursing diagnoses are and some examples that relate to our lecture today. Then next, once we formulate our nursing diagnoses, we're going to create a plan and put that care plan into action and implement that. Okay, so nursing interventions are directed toward maintaining the patient's safety and wellness in all types of settings. We promote health in different ways. Okay, there's passive strategies and there's active strategies. So passive strategies, some examples I've got here for you. Through public health and government legislative interventions, maybe things like sanitation laws, clean water laws. So those are some examples of more passive strategies in promoting health. Some more active strategies. So the individual is actively involved through changing their lifestyle to a healthier way of living. Maybe things like, changing their habits in vehicles. They're now wearing seat belts. Participating in wellness programs at work or an exercise program. So those are more active strategies that help promote wellness. In your fundamentals textbook, on page 699 to 700, There is a table discussing accident prevention strategies and promoting safety and wellness at various ages. I would recommend looking over that. That's a good table there. It's some good information that it provides for different age groups. First aid things that are important to know in what we would consider emergency first aid. A patient who is experiencing bleeding after maybe a traumatic event, an allergic reaction, a patient who's in a state of shock, a patient who's experienced a burn, strains or sprains, dislocations or fractures, neck or back injuries, a poisoning event, bites or stings, heat and cold exposure, a choking event, seizure. Also knowing CPR guidelines for the healthcare setting as well as in the community with the more promotion of hands-only CPR in the community setting. So those are all important things to know as far as first aid. The injury prevention strategies that we develop, can be created through different methods. And so we start with engineering, and that is basically, trying to modify the patient's environment to help decrease or even eliminate that risk of injury. So we as nurses do that a lot, creating a safer environment for the patient. Through enforcement, that could be things such as, regulations or laws that are put into place that can help modify behaviors to make a more safe environment. That could be things like helmet laws, seatbelt laws. Education, this is another big area that nurses can make a difference. We educate our patients a lot on how to modify their behavior in order to create, a healthier life, promote wellness, and create a safer environment for the patient. And then economically, creating financial incentives to help, implement injury prevention measures. So those are just some different strategies that you can see used, and some of those more so in the world of nursing than others. Now let's look at different age groups and see what, kind of the high-risk concerns are for each age group and some, kind of specific things to consider. So we'll start with the prenatal stage. And in utero, of course, whatever affects mom will affect the baby. And so we need to do lots of education for mom about avoiding maternal smoking, avoiding alcohol consumption, addictive drugs, pesticides, in the environment, radiation exposure in the environment, and maintaining a healthy nutritional status, promoting the use of prenatal vitamins with folic acid and DHA. We know those do play a factor in helping to prevent some birth defects, such as neural tube defects like spina bifida. So they can make a difference there. Then we move into infant age. Of course, they are totally dependent on their care providers, and they should never be left unattended. Teach parents, no propping bottles. That puts them at risk for choking concern. Crib safety, again, as I mentioned earlier, no pillows, no blankets in the crib. Should sleep alone, so there's no risk of smothering the infant in the bed with the adults. Toy safety, no plastic bags or balloons. They should not be playing with those things unattended. They can choke on, try to put them in their mouth and choke on them, and suffocation concerns there. Of course, shaken baby syndrome is a concern, and so teaching parents how to deal with, those moments of frustration that happen, and, how to cope with those feelings in a safe way. Everything goes into the baby's mouth, of course. It's how they explore their environment. It's them trying to learn. So it's natural, but we need to know that and realize that. So teaching parents how to modify the environment so that it is safe for them to be able to explore their environment. And then some other concerns, falls, as they're getting to that closer to that 1 year age and learning how to walk, and lots of concerns there. Electric shock, if they're getting a hold of electrical cords, again, everything goes into their mouth, so that's a concern. Scalds or burns, getting a hold of hot water, make sure that bath water, safe temperature, all of those. And then poisoning, make sure there's all child locks on all the cabinets, that they can't, they shouldn't be able to get into those high risk poisoning items. Lead paint exposure, and that's something that typically is assessed in well child visits with the pediatrician. Is there a risk for that in the home? Especially in those older homes. And then proper car seats, make sure that they're utilizing those at the correct ages, and that parents are installing them properly. Otitis media is middle ear infections. Those are common for this age group. Okay, so teaching parents when to seek medical attention, when the child's ill, at what point they need to bring them in to see the doctor. Then we move into toddler age. These guys are very busy, they're very curious, so again, child-proofing the home environment is very important, and they do exert their independence as they're learning, to do more, and they're learning more things. Unfortunately, we can see, increased risk or increased rates of abuse and neglect because of the child, exerting their independence. They can throw tantrums, or have episodes there where their behavior can then be frustrating to the parents, and then unfortunately parents can lash out, and you can see those concerns. So always be assessing for those signs of those situations. Routine is important for kids, and discipline is important, and so make sure that parents understand how to do those properly. Other problems, drowning, again, they're very curious, and they're going to explore their environment, so they may run off on their own, and in those water environments that can be very risky. Choking, there are many common foods that are a high concern, those cylinder-shaped foods like grapes, hot dogs, popcorn, some candies, all of those can be a concern for choking, so how can we give those safely so that they decrease that risk. Proper car seats again, and those contagious diseases that at this age they're getting to be around more kids frequently, so spreading those germs, there can be more communicable diseases that are spread. Preschool age, again, they are learning a lot, they're exploring their environment, becoming a little more independent. You can see common issues at this age: playground injuries, traffic injuries. We really have to teach bike safety and helmet safety early on, so kids understand how important those are, how it can keep them safe in an accident having their helmet on. So those are two very big things. Animal bites, they can kind of get into the animal's space, and that can make them nervous, and then they lash out. So you can see that at this age. Still, need to be supervised in the bathtub, even though they're getting old enough, they're getting more independent, still need supervision. And, we always need to start safety education early in life. So preschool age is a great age to start doing that, and, the earlier the better. Moving into school age. Again, exploring their boundaries, learning how to be more independent. This can lead to concerns of accidents, traumas. That is one of the leading causes of injury and death that we see at this age, especially during summer months. There's a lot of these injuries that occur. Again, teaching them to never talk to strangers. Even, this early we need to start talking to them about sex education, anti-drug and alcohol education. And then the common injuries that we see with these kids: broken bones, the accidents, traumas, burns, abrasions, bike and automobile injuries. So lots of accident prevention and education with this group. And then adolescent age, they're trying to, figure out who they are. They're exploring all of that. Tend to be a little bit more risky, so risk takers. Again, things like not wearing seat belts in automobiles, not wearing helmets on bikes, or ATVs, different vehicles like that. Motor vehicle accidents and VAs are the most common cause of injury and death in this age group. You could also see traumatic brain injury, or TBI, as a result, and that, of course, can be a life-changing event. And then seatbelt education is so big with this age group, and sometimes it doesn't matter how much you try to educate them. They're going to make their own decision, but the more that we try, the better the odds are that we can get through. So we got to make sure that we do that. And other problems to consider: sports injuries, tobacco, alcohol, drug use, overdose episodes, experimentation with sex, eating disorders, suicide, rape, internet and social media issues. And you can see all of these, from high school age through college age kids. So lots of education needed to help prevent some of these concerns. Then we move into adult age, and stress, of course, is a big issue in adult world. Everyone has jobs, maybe school that they're juggling, family responsibilities, and stress is a part of our everyday lives, but it's how we cope with that stress that's what's most important, because it can have a long-term effect on our health. So good stress management and coping with that. Lifestyle choices, things that can affect our health. More sedentary lifestyle, poor eating habits will have long-term health concerns. Some of those unhealthy habits, smoking. All adults need to be having those preventative care, yearly exams. Women having gynecological exams, all of those need to be done yearly. Good dental care, every year. Drug and alcohol use, can have effects on our health. So just trying to promote all of those healthy behaviors, and, also being on the lookout for any signs of domestic or relationship violence, and intervening in those situations appropriately. And then we move into the older adults, and the safety concerns are really the primary issue with this age group. Falls are just one of the biggest concerns, and it's because there's just so many complications after a patient experiences a fall. And the reason that we see this as such a high risk in this population is, as we age, we have a decreased balance, increased weakness, decrease in our reflex time, and could also be secondary to disease processes or medication side effects. So there's lots of different factors that play into this, but there is such a high risk, and there's many complications, broken bones, chronic, just injuries that are very serious and debilitating, and could also lead to death. And we have this picture here of the fall cycle. We know that when a patient experiences a fall, an elderly patient, then they develop this fear of falling again, and especially if they suffered any injury from the fall. What that does is it then causes them to be less active, because they want to try to prevent that from happening again. But then when we decrease activity, our bodies start losing muscle strength. Our balance starts to decrease. So then that just puts us at a higher risk for falling again. So it is kind of a vicious cycle, and we do see this with the geriatric population. Some other concerns: poisoning, if they're taking incorrect amounts of medications. If they have impaired vision, they're not able to see how much they should be taking. Depression and suicide is a concern in this age population. Elder abuse, sensory alterations, and those could lead to things like a motor vehicle accident if they have impaired vision or hearing. And then medications, side effects of those, again, can put a patient at risk for a fall and just put their safety at risk. So now that we've looked at all the different age groups, let's continue on how to prevent falls from happening. So, fall prevention, some things we need to start with is, first, when we're admitting a patient to, a healthcare facility, we need to orient that patient to the environment so that they are comfortable with it, they're aware of where everything is at. Then we need to do some assessments, assess their physical condition, what's their activity level, assess their mobility status. Are they able to ambulate safely and transfer safely independently, or do they need assistance? And if they're using any assistive devices, are they using those correctly? We always need to ensure when a patient is in their room and they're in their bed, we got to make sure before we leave that room that the bed wheels are always locked and the bed is in the lowest position. There are going to be times where we may raise the bed up if we're doing patient care, and that's okay. But whenever we're finished, we always got to make sure that we check those wheels on the bed, that they're locked, and that bed gets put back down into the lowest position. So those are two things as nurses that we should always be checking safety-wise every time with our patients. And then we always need to ask ourselves, who is kind of, my highest risk concern for falling? So I'll just list some here for you guys. Older adults, and again, a lot of scales will consider 65 and older in that age group. Also, the younger patients, infants and toddlers as well. Has the patient had a history of a previous fall? Do they have any gait, balance, or mobility problems? Do they have that postural hypotension or the orthostatic, where their blood pressure decreases when they go from a lying position up to a standing position? Sensory impairment could be impaired vision or hearing. Urinary or bladder dysfunction, that can maybe cause them to be a little more impulsive to go up to the bathroom. If the patient has any confusion or disorientation impairing their judgment, a slowed reaction time, if they're in an unfamiliar environment, and looking at their medications. Are they taking any medications that affect the central nervous system? Even some cardiovascular medications can put patients at higher risk if it's going to decrease blood pressure, or medications that increase fluid excretion like diuretics, that can put them at risk for being impulsive to get up. So all of those things are risk factors, again, to consider. Okay, we always want to assess and monitor safety for our patients. We need to anticipate their needs. What is it that they will most likely need whenever I leave the room? So what are those things that I can provide for them to help them to be, a little more safe and less impulsive in their, mobility. Keep the patient's room close to the nurse's station if you have a patient who is pretty high risk for falls. Maybe their cognition is impaired. So we'd want to keep a close eye on them. Check on the patient frequently. Assist the patient with bathing. If they're at risk for falls, we need to stay with them in the room. And while they're bathing, we need to help them with that. Nighttime is also a very high risk time. Patients can get kind of disoriented if the lights are dim, and can get up out of bed and not know where things are at. So that can be a very high risk time as well. Some other things that we can do to prevent falls. As you can see here in the picture, this fall risk identification band, any patient who is a fall risk, we need to be sure that we place that on the patient. Also, these non-skid socks here, make sure that they're wearing that special footwear, and have that on while they're up and ambulating. It's going to help keep them safer, so they don't slip and fall. Also, it should be documented in the patient's chart that they are a high risk for falls. Also, all medical and nursing staff need to be aware of the patient's fall risk. And as nurses, we should be assessing the patient's fall risk every shift to look for any changes in that fall risk status, see if anything is changing over time. And then, when we care for the patient, always assisting them as needed, depending on if that's a 1 or 2 person assist, how many people that they need, and performing just their, the ADLs, activities of daily living. So always just make sure that we're available to the patient to help with those things. We should always make sure that the patient has their call light available. There's some pictures here of some different variations of what those can look like. But when we're admitting a patient, we need to make sure that we show them, what the call light is, how to use that, what all the different buttons mean, and always encourage the patient to use their call light every time we interact with them, and before we leave the room, tell them, to have that readily available. And before you leave the room, make sure you hand that to the patient so they always have it available to them. And then when a call light does go off, we need to make sure that we are answering those promptly so the patient doesn't have to wait long periods of time for us. The longer they have to wait, the higher the odds are, or the risk is, that they just will get up out of bed on their own. So we got to answer those promptly. Keeping those supplies close, kind of talking about anticipate the patient's needs. Ask the patient what items would they like easily accessible to them. That could be maybe a glass of water, their phone, if they have books or magazines, Kleenex, a urinal, just some examples of what would be, good to have at the bedside table for them. And make sure any of those items that they request are always at the bedside table before you leave the patient's room so that they have those items accessible. And again, before you leave the patient's room, you always got to make sure that those bed wheels are locked and that the bed is put back down into the lowest position. Some safety equipment just to be aware of, to introduce you to here, and make sure that patients are properly using these. The bedside commode, or BSC, that's the picture in the middle here. Again, the grab bars on those, make sure patients are using those correctly, because sometimes if they put too much weight on one side or the other, it could cause them to tip over and cause a fall. So just make sure that they're using those appropriately. A shower chair is on the bottom picture here, that patients can use if they can't stand for long periods of time in the shower. It's just overexerting, fatiguing, so they can sit in that in the shower. And any other assistive devices, the walker there on the top picture, just make sure that they're using those safely. Make sure when they are up and ambulating that they have that non-skid, either the socks or shoes, whatever footwear that they have. In the bathroom, make sure there's non-skid bath mats, just to keep that safe and free from a slip and fall. Keeping the floor free from clutter at all times, both in the bathroom and out in the patient's room. Sometimes glaring from light can, cause concerns for some patients, so just make sure that they're not having issues with that. Safe use of the bed side rails, and sometimes patients will use those to try to, move around in the bed or to get them to sit up on the side of the bed. Just make sure that they're using those safely and they're not causing any safety concerns like on their arms. And then use of any of those sensory devices, again, like glasses, hearing aids, make sure they have them and that they're working properly. So here's a fall risk model that I want to show you guys. It's another example of a fall risk assessment tool. It's the Hendrick 2 fall risk model, and what this has is actually two components to it. On the top part are the risk factors, so like some of the ones that we talked about earlier, patients who have like confusion, disorientation, impulsivity, symptomatic depression, altered elimination, dizziness, vertigo, male gender. Males just tend to be a little more impulsive and tend to get up on their own and not ask for assistance. So on this scale, they get awarded 1 extra point. And then if patients are on any medications that are anticonvulsants, those can be sedating and affect the central nervous system, so that's why they're a higher risk. And then any benzodiazepine medications, again, those can cause sedation and alter the central nervous system. So those would be all of the things that the nurse would assess and would total up the points there on the risk factor. And then the second part of this is called the get up and go test. And this is where you actually have a patient physically, they sit in the chair and then they rise from the chair, and you're assessing their ability to do that, and how safe was it? Did you notice any concerns? So If the patient is able to rise in a single movement and they have no loss of balance, that would be a 0, so that would be, the most optimal score there. If they have to kind of push up on the armrest but are successful in one attempt, that would get 1 point. If they have multiple attempts and eventually are successful, that would be 3 points. And then if they're unable to rise without assistance and during the test, then that would get the most points. So then you total up the score there between the two, and a score of 5 or greater is considered a high risk for falls. So on this slide here, there is a video of the Hendrick II fall risk model being used and nurses performing the Get Up and Go test. It's called the How to Try This video. You will see when you click on that link, it will take you to the website, and you just need to click on this video, and you need to watch this video so that you can understand how nurses perform fall risk assessments and all the different things that we're looking for. And then once a patient is identified as a high fall risk, what interventions do we implement then? So please take time to watch this clip on your own. Okay, so sometimes even with our best efforts, there are patients who experience a fall. So what are our steps when that happens? First thing, you don't want to move the patient until you do kind of a quick assessment of them, and you need to check a set of vital signs and just do a quick look over on the patient and see if you can find any obvious injuries. So look at the head, the face, the trunk of the body, their back, and the upper extremities and lower extremities, and just see if you can identify any obvious injuries right from the start. So do that assessment, check their vital signs, okay, provide any first aid that may be needed, if they got any, cuts, scrapes, anything like that. And then at that point, if the patient is stable to move, there's no obvious injuries, they're feeling okay, and vital signs are all stable, you can then assist them back to bed slowly. Start by first sitting the patient up and kind of get them, kind of reoriented and get them, get their bearings, and then you can stand the patient up and walk them back to bed. Once the patient is back to a safe place and they are not critically hurt or there's no obvious injuries, we need to assess how the patient felt. So if you can ask the patient if they can recall what happened, we need to assess that. And then we need to notify the physician of the fall, let them know what happened, the patient's current condition. At that point, you may possibly receive some orders from the physician for further testing to look for, any other injuries. So maybe x-rays, scans, different things like that to look for any, broken bones, scans of the brain to look for bleeding, especially patients that are on blood thinners. So there's a lot of things to consider. So maybe anticipate, receiving some orders from the physician for that. And then we need to notify the family, and we need to do, promptly notify them of the event, honest notification, and then document the event, okay? And some facilities will call that a safety event reporting or an incident report. That can be called a couple different things. But whenever, I want to go back to the notifying the family, when you're notifying family members of, an injury event, we need to, always be honest, be open about what happened. And so here's it's called a statement of principle that the National Patient Safety Foundation developed. And it says, when a healthcare injury occurs, the patient and the family or representative are entitled to a prompt explanation of how the injury occurred and its short-term and long-term effects. When an error contributed to the injury, the patient and the family or representative should receive a truthful and compassionate explanation about the error and the remedies available to the patient. They should be informed that the factors involved in the injury will be investigated so that steps can be taken to reduce the likelihood of similar injury to other patients. Healthcare professionals and institutions that accept this responsibility are acknowledging their ethical obligation to be forthcoming about healthcare injuries and errors. The National Patient Safety Foundation urges all healthcare professionals and institutions to embrace this principle in dealing with patients honestly and openly. So at this point, we will end our first hour of lecture, and we will continue on in the next video with the remainder of the safety lecture.